It's the showdown between Zepbound and Wegovy. Zepbound versus Wegovy. Which is better? A head-to-head battle based on the results of the just completed SURMOUNT-5 trial. Hi again, everybody, and welcome to a special edition of the PharmEasy Tutor. Today, we'll be comparing the two weight loss drugs, Zepbound and Wegovy, to find out which one works better at reducing weight. There are currently two FDA-approved injectable GLP-1 drugs for weight loss, Tirzepatide or Zepbound and Semaglutide, Wegovy. Which of these two drugs are better at reducing weight? To find the answer, we will review the results of the recently published SURMOUNT-5 trial. The SURMOUNT-5 trial was published in the New England Journal of Medicine in May of 2025. It is entitled Tirzepatide as compared with Semaglutide for the treatment of obesity. The author is Louis Aron. Before we get into the study, let's first review some background information on these weight loss drugs. We can begin by talking about the incretin hormones, specifically GLP-1 and GIP. After eating a meal, in response to the presence of food in the gut, the small intestine releases incretin peptide hormones. The two main incretin hormones are GLP-1, or glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. GLP-1. GLP-1 receptors are present in several areas of the brain involved in appetite regulation, the brainstem and hypothalamus. GLP-1 acts centrally in the brain to suppress appetite centers, causing a loss in appetite and reducing food intake. GLP-1 also slows gastric emptying, how quickly food leaves the stomach, promoting a feeling of fullness, satiety, thereby reducing appetite and causing weight loss by eating less. Finally, GLP-1 stimulates insulin secretion and inhibits glucagon secretion, thus lowering blood sugar. GIP. GIP is the main incretin hormone in healthy people, responsible for most of the incretin effects. GIP further contributes to the regulation of food intake by reducing appetite, increasing sensitivity to insulin, and improving how the body breaks down sugar and fat. GIP amplifies GLP-1's effects. Here's a nice diagram depicting where the incretin hormones GLP-1 and GIP work. Now let's talk about the GLP-1 agonist drugs. Tirzepatide or Zepbound and Semaglutide, Wegovy, are part of a new generation of highly effective medications for the management of obesity called GLP-1 agonists. Tirzepatide is a synthetic version of two naturally occurring incretin hormones in the gut named GLP-1 and GIP. It is thus called a dual agonist. Semaglutide is a synthetic version of the naturally occurring incretin hormone in the gut named GLP-1. This table will compare the GLP-1 agonists. Tirzepatide, or Zepbound, was approved in 2023. It's manufactured by Eli Lilly, and its mechanism is that it is a dual GLP-1-GIP receptor agonist. The official FDA indication is for weight loss for obesity. Semaglutide, or Wegovy, was approved in 2021. It's manufactured by Novo-Nordisk, and its mechanism of action is that it is a GLP-1 receptor agonist. Its approved indication is weight loss for obesity. As for the popular drug Ozempic, you probably have heard that it is being used for weight loss. Ozempic and Wegovy share the same chemical active ingredient, semaglutide. However, Ozempic is not indicated for weight loss by the FDA, but it is indicated only for the treatment of type 2 diabetes. Therefore, Ozempic is currently being used off-label for weight loss. An important point to remember that will come up later is that Tirzepatide is a dual GLP-1 and GIP receptor agonist, where Semaglutide is only a GLP-1 receptor agonist. Tirzepatide and Semaglutide work by mimicking the effects of incretin hormones in the body. They target and activate incretin receptors in the brain that regulate appetite and control hunger to suppress appetite and hunger. They slow gastric emptying time, promoting a feeling of fullness or satiety by acting on receptors in the brainstem and hypothalamus. These actions reduce appetite and cause weight loss by eating less with decreased calorie intake. And finally, they stimulate insulin secretion and reduce glucagon secretion in a glucose-dependent manner. These effects can lead to a reduction of blood glucose. So how good are the GLP-1 agonists for weight reduction? Clinical efficacy. Clinically meaningful weight reductions have been observed with both medications. Tirzepatide has reported mean weight reductions of up to 22.9% after nearly 3.5 years of treatment. Semaglutide has seen mean weight reductions of 16.7% after nearly 2 years of treatment. However, a head-to-head comparison of the efficacy and safety of Tirzepatide versus Semaglutide in adults with obesity but without type 2 diabetes has not yet been performed. Therefore, to address this, investigators conducted a 72-week randomized controlled trial to evaluate the efficacy and safety of the maximum tolerated dose of Tirzepatide, 10 mg or 15 mg, as compared with the maximum tolerated dose of Semaglutide, 1.7 mg or 2.4 mg, in adults with obesity without diabetes. Now let's move on and talk about the specifics of the SURMOUNT-5 study. Trial design. This was a phase 3b multicenter parallel arm open label randomized controlled trial that was conducted during 72 weeks at 32 sites in the United States and Puerto Rico. The trial was conducted between April 21st, 2023 and November 13th of 2024. Participants. Participants were adults with obesity but without type 2 diabetes. Participants were included if they were 18 years of age or older and had a body mass index or BMI of greater than or equal to 30 or a body mass index of greater than or equal to 27 and at least one pre-specified obesity-related complication, hypertension, dyslipidemia, obstructive sleep apnea, or cardiovascular disease, and reported at least one unsuccessful dietary effort for weight reduction. Key exclusion criteria included a diagnosis of diabetes, previous or planned surgical treatment for obesity, treatment with a medication for weight reduction or a GLP-1 receptor agonist within 90 days before screening, or a change in body weight of more than 5 kilograms within 90 days before screening. Procedures. Participants were randomly assigned in a 1-to-1 ratio. Drug dosages were slowly titrated upwards in accordance with recommendations from the prescribing information until participants received the maximum tolerated dose of each drug. Treatment was administered subcutaneously by the participants once weekly for 72 weeks. Tirzepatide was initiated at a dose of 2.5 milligrams once weekly, and the dose was increased by 2.5 milligrams every 4 weeks until a maximum tolerated dose of 10 milligrams or 15 milligrams was reached. In the diagram, you can see the arrow pointing at the drug regimen as it is titrated up. Semaglutide was initiated at a dose of 0.25 milligrams once weekly, and the dose was increased every 4 weeks from 0.25 milligrams to 0.5, 1, 1.7, and 2.4 milligrams until the 2.4 milligram dose was reached. If unacceptable side effects were associated with the 2.4 milligram dose, the participant could continue receiving the 1.7 milligram dose as the maintenance dose. If a participant's BMI decreased to 22 during the course of trial treatment, efforts were made to maintain body weight at that level. Counseling included advice to adjust caloric intake. Furthermore, the investigator had the option to reduce the dose, for example, decreasing the Tirzepatide dose from 15 milligrams to 10 milligrams, or from 10 milligrams to 5 milligrams, or decreasing the Semaglutide dose from 2.4 milligrams to 1.7 milligrams. All the participants received counseling on nutrition and physical activity. Endpoints and assessments. The primary endpoint was the percent change in body weight from baseline to week 72 with Tirzepatide as compared with Semaglutide. The secondary endpoints were a weight reduction of at least 10, 15, 20, and 25% from baseline to week 72, and a change in waist circumference from baseline to week 72. Safety assessments included adverse events and serious adverse events that occurred during the reporting period, including adverse events that led to the discontinuation of Tirzepatide or Semaglutide. Major adverse cardiovascular events, pancreatitis, and deaths were reviewed by an independent external adjudication committee. Before we present the results of the study, here's a brief message from the PharmEasy Tutor. To stay updated with each installment of the PharmEasy Tutor, make sure to subscribe to this channel. It's easy. Just click on the black subscribe button below to change it to the word subscribed. Then, to get notified whenever a new video comes out, click the down arrow and then select All. Also, if you like videos such as this, please take a moment to click on the thumbs up icon below to change the color to black. Thanks for your help with this. Now on to the results of the study. Participants. A total of 750 participants underwent randomization and received at least one dose of Tirzepatide or Semaglutide. In the Tirzepatide group, 89.3% of the participants received at least one 15 milligram dose, and in the Semaglutide group, 92.8% received at least one 2.4 milligram dose. In general, demographic and clinical characteristics of the participants were similar in the two groups. The mean age of the participants was 44.7 years. The majority were women, 64.7%, and white, 76.1%. The mean body weight was 113 kilograms, or 248.6 pounds. The mean BMI was 39.4, and the mean waist circumference was 118.3 centimeters, or 46.6 inches. The average reported duration of obesity was 16 years. At least 2 obesity-related complications were experienced by 50.1% of the participants. Here is a table comparing the demographics of the participants. Of note is that the study included approximately 20% African American and 25% Hispanic participants. Also of note is that the average baseline weight of these participants was 113 kilograms, or 249 pounds, and their waist size was 118 centimeters, or 47 inches. The majority of participants, 70%, had a body mass index of greater than or equal to 35. A BMI of 30 to 39.9 is considered obese, and a BMI of 40 or higher is considered morbidly obese. Here are the results for the primary endpoint, the percent change in body weight. The mean percent change in body weight from baseline to week 72 was minus 20.2% with Tirzepatide and minus 13.7% with Semaglutide. Tirzepatide was superior to Semaglutide with respect to weight reduction, estimated treatment difference of minus 6.5 percentage points, a p-value of 0.001. How about the absolute change in body weight? The mean change in body weight from a baseline weight of 113 kilograms or 249 pounds to week 72 was minus 22.8 kilograms or minus 50 pounds with Tirzepatide and minus 15 kilograms or minus 33 pounds with Semaglutide. You can see in the time versus body weight diagram at 72 weeks that there is a separation of a difference of 17 pounds. In both trial treatment groups, the weight reduction was approximately 6% greater among women than among men. The degree of weight loss. More participants treated with Tirzepatide than those treated with Semaglutide had reductions in body weight of at least 10, 15, 20, and 25% from baseline, a p-value of 0.001. In the diagram, you can see that at each target reduction level, 10, 15, 20, 25%, Tirzepatide had a higher number of participants achieving that level than Semaglutide. In other words, participants in the Tirzepatide group were more likely than those in the Semaglutide group to have weight reductions of 10%, 15%, 20%, and 25%. This table reviews the results that we discussed so far. For the mean percent change in body weight at week 72, Tirzepatide had a minus 20.2% reduction and Semaglutide had a 13.7% reduction, a treatment difference of a minus 6.5%. The mean change in body weight at week 72 was a minus 22.8 kilograms or 50.2 pounds for Tirzepatide and minus 15.0 kilograms or 33 pounds for Semaglutide, a difference of minus 7.8 kilograms or 17.2 pounds. The mean percent change in body weight at week 72 for females was 18 to 23.8%, which is higher than for males with a value of 11 to 17.8%. In the section below in yellow, you can see the weight reduction stratification, a secondary endpoint. It is interesting to note that about 1/3 of the Tirzepatide-treated participants achieved an outstanding weight loss of over 25%, and about 1/5 had a weight reduction of over 30%. Change in waist circumference. The mean change in waist circumference from baseline to week 72 was minus 18.4 centimeters with Tirzepatide and minus 13 centimeters with Semaglutide, minus 7.2 inches versus minus 5.1 inches. Tirzepatide was superior to Semaglutide with respect to reduction in waist circumference, an estimated treatment difference of minus 5.4 centimeters or minus 2.1 inches, a p-value of 0.001. What about cardiometabolic risk factors? Systolic blood pressure showed improvements with Tirzepatide with a mean change of minus 10.2 millimeters of mercury, and with Semaglutide, a mean change of minus 7.7 millimeters of mercury. Diastolic blood pressure also showed improvements with both treatments. Glycated hemoglobin, fasting serum glucose, and lipid levels improved with both trial treatments, which is consistent with previous trials. For both trial treatments, a comparison of weight reduction categories minus 10%, 10 to minus 20%, 20 to minus 30%, and greater than or equal to 30% showed that the higher categorical weight reductions were associated with greater improvements in each cardiometabolic risk factor. This table reviews the results of the secondary endpoint, waist circumference. Here are the improvements in blood pressure. Adverse events. The most frequently reported adverse events in both treatment groups were gastrointestinal. Nausea 44%, constipation 28%, diarrhea 23%, and vomiting 18%. Most were mild to moderate in severity and occurred primarily during dose escalation. Tirzepatide had more injection site reactions at 32, 8.6%, compared to semaglutide with only 1.3%. Erythema, pruritus, edema, induration, and pain were the types of injection site reactions. Report of at least one adverse event that occurred or worsened during the treatment period occurred in 76.7% of patients on Tirzepatide and 79% of patients on semaglutide. Serious adverse events occurred in 18 Tirzepatide patients, or 4.8%, and in 13 semaglutide patients, or 3.5%. Trial treatment was discontinued because of adverse events in 23 Tirzepatide patients, 6.1%, and in 30 semaglutide patients, 8%. Treatment discontinuation due to gastrointestinal events occurred in 10 Tirzepatide patients, 2.7%, and 21 semaglutide patients, 5.6%. One adjudication-confirmed case of pancreatitis was reported in the semaglutide group. No adjudication-confirmed major cardiovascular events, deaths, cases of medullary thyroid cancer, or cases of pancreatic cancer were reported. The results with respect to adverse events of special interest were consistent with those of previous trials. Adverse events of special interest are noted in the table below. Summary. The SURMOUNT-5 study was a head-to-head comparison of the efficacy and safety between Tirzepatide and semaglutide in the treatment of obesity in non-diabetics. It was a randomized, open-label, controlled trial conducted over 72 weeks. The study found that Tirzepatide was superior to semaglutide, achieving a weight loss reduction of 20.2% versus 13.7%. A difference of minus 6.5 percentage points. This meant that participants with an initial average body weight of 113 kilograms, or 249 pounds, lost an average of 23 kilograms, 50 pounds, by using Tirzepatide over a period of 72 weeks, about 20% of their weight. Likewise, participants receiving semaglutide lost an average of 15 kilograms, or 33 pounds, about 14% of their body weight. Weight reduction was greater among females than among males by 6%. The mean percentage change in body weight at week 72 was 24% in females and 18% in males in the Tirzepatide group, and 18% female versus 11% male in the semaglutide group. The current trial included a higher percentage of men, 35%, than in previous trials. In addition, Tirzepatide reduced participants' waist circumferences by an average of 18.4 centimeters, 7.2 inches, compared to semaglutide, 13 centimeters, or 5.1 inches, a statistically significant difference. It has been previously reported that each 5 centimeter increase in waist circumference predicted a 7% increase in mortality among men and 9% increase among women. Cardiometabolic risk factors, including systolic and diastolic blood pressure, glycated hemoglobin, fasting serum glucose, and lipid levels, showed improvement in both Tirzepatide and semaglutide treatment groups. Greater improvements in these parameters were observed when there was a greater reduction in weight. Both tirzepatide and semaglutide had safety profiles consistent with those in previous trials. The most frequently reported adverse events in both treatment groups were gastrointestinal, nausea, constipation, diarrhea, and vomiting, and most were mild to moderate in severity and occurred primarily during dose escalation. Tirzepatide caused more injection site reactions, 32 or 8.6%, compared to semaglutide, which only had 1.3%. Injection site reactions included erythema, pruritus, edema, induration, and pain. One adjudication-confirmed case of pancreatitis was reported in the semaglutide group. Here are some items for discussion. A possible reason why tirzepatide achieved a greater degree of weight reduction compared to semaglutide can be attributed to their mechanisms of action. Both drugs are GLP-1 receptor agonists, but tirzepatide also pharmacologically activates a second metabolic receptor, GIP. GIP has both overlapping and non-overlapping expression and function to GLP-1. This additional action, its dual agonism, can possibly explain why tirzepatide is superior to semaglutide. Limitations of this trial were that it was not double-blinded and that Eli Lilly, the manufacturer of tirzepatide, funded and sponsored the study. The authors note that one of the strengths of the study was the diversity of the participants, with 19% reporting their race as Black and 26% reporting their ethnic group as Hispanic or Latino, which is representative of the populations living with obesity. Adherence to proper compliance to the drug regimen to gain maximal clinical benefit is a critical issue to discuss. Since 90% of participants in this trial received at least one maximally tolerated dose, this meant that they were able to successfully titrate up the drug over a prolonged dose escalation period lasting 4 to 5 months. In the real world, without close guidance of a study, patients may have difficulty properly following the dose titration schedule to achieve maximally tolerated dosages. Further complicating things is that the duration of the study lasted 72 months, almost 1.5 years. Although noticeable weight loss seemed to occur at 24 weeks, lack of motivation by patients to continue for 72 months to observe maximal benefit may lead to poor patient compliance with the drug regimen, schedule, and to suboptimal outcomes. The cost of these weight loss drugs is a key factor due to expense. Many private or commercial insurances cover them, depending on the plan. At the time of this writing, Medicare does not offer coverage, but Medicaid does offer coverage in 14 states. Recently, as supply issues have eased, prices for this class of drugs have declined. Wegovy's list price is $1,349 per month, but if you are uninsured or if your insurance doesn't cover Wegovy, then through a direct-to-consumer self-pay program, it can cost $499 per month. Zepbound's list price is $1,086 per month, but if you are uninsured or if your insurance doesn't cover Zepbound, then through the company's self-pay program, Lilly Direct, the starter doses of 2.5 and 5 mg cost $349 per month, increasing to $499 per month with larger doses 7.5 and 10 mg. Ozempic costs $998 per month with no direct-to-consumer program. Conclusion. In this trial, among participants with obesity but without diabetes, treatment with tirzepatide, a dual GLP-1 and GIP receptor agonist, was superior to treatment with semaglutide, a selective GLP-1 receptor agonist, with respect to reduction in body weight and waist circumference at week 72. Although tirzepatide showed superiority, semaglutide also demonstrated significant weight reduction. This current trial shows that higher magnitudes of weight reduction have now become more readily achievable and sustainable with these new and exciting GLP-1 receptor agonist drugs. Weight loss and waist circumference were not the only benefit from using these drugs. Improvement in cardiometabolic risk factors, including blood pressure, glycemia, and lipid levels, were observed in both Tirzepatide and Semaglutide groups, which can lead to better physical functioning, improved health, and an enhanced quality of life. So which do you choose? Well, it seems like both drugs work effectively to reduce weight, as long as GI side effects are tolerated. Because Zepbound has a dual agonist action, it performs significantly better than Wegovy. However, Wegovy still resulted in very good weight loss, 14%, compared to 20% for Zepbound. Based on this study, both drugs appear to work well and result in significant weight loss in the obese population and can lead to positive cardiometabolic outcomes. Thanks for tuning in to watch this installment of the Farm Easy Tutor. I hope you learned something that you could use at school or in practice. If you would like to continue to see more of these types of tutorials on YouTube, please make sure to click on the black subscribe button below to change it to the word subscribed. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to black. Also, if you have any comments or questions, please feel free to add them in the comments section below or share this site with someone else. Stay tuned to the Farm Easy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.